All right. Hi, everyone. Welcome to LA, California. We've been doing this series now for a little over a year, and I'm more excited than I've ever been to be sharing the stage with Dr. Ugalde and Dr. Najmeh, who are really brilliant surgeons, and try and give you some new perspectives, different views on this evolving space. We're going to get right to it because we have a ton of stuff to cover, and we want to give some time for you guys to get in on some questions. So, as I said, I'm very lucky to share this opportunity with Dr. Paula Ugalde, who's Associate Professor of Thoracic Surgery at Brigham and Women's, Harvard Medical School, internationally recognized for her role in developing minimally invasive surgery and a leading voice in the domain. And my colleague, Dr. Sarah Najmeh, who's an assistant professor back home where I work as well at McGill University, who's now 3 years out of practice, and I'm proud to say has probably operated on more patients after chemoimmunotherapy than most people in the room here. So she actually brings a wealth of experience despite her I guess, junior status. So I wanted to showcase what she's been doing. So for our virtual attendees, welcome. These sessions are always telecast simultaneously. We'll be having some polls, so please feel free to use the iPads that you have in front of you to participate and give us a sense of your take on some of these questions. And we'll be taking some Q&A at the end. You can access the material on PeerView after the fact. There's a lot of good content there. So educational goals today is really to keep everyone up to date on the evolving evidence around the use of immunotherapy for patients with resectable non-small cell lung cancer, and really focus on some of the skills that might be required to treat these patients and some of the concepts we need to keep in mind to do a good job for our patients. So I'll start with a review of the data, but before we get into that, if you don't mind picking up those iPads and trying to answer a few of these questions, just to get a sense of where people stand. So, for a fit patient with resectable stage 3 disease, would you prefer to do upfront surgery followed by chemo immunotherapy regardless of their PD-L1? Do you favor upfront surgery followed by chemotherapy and then adjust based on the PD-L1 greater than 1% or greater than 50% for answers 2 and 3? Are you a neoadjuvant chemoradiation followed by surgery person, or do you favor neoadjuvant chemoimmunotherapy followed by surgery? So please go ahead and answer. We'll review all the answers at the end of the session. We can go on to the next question. This is the same question now, but for stage 2 patients. Same answers. If you guys don't mind populating those. And we'll go on to the next one. So this is a scenario that comes up every now and then, and I personally struggle with what the right thing to do is. A patient who's fit, again, assuming a well patient who could tolerate surgery, 4 centimeter left upper lobe mass, who on EBUS has a positive 4L lymph node. What do people prefer to do in these patients? Are you offering these patients upfront surgery and then tailoring the therapy afterwards? Do you offer them concurrent chemoradiation, no surgery in this scenario? Neoadjuvant chemoimmunotherapy and surgery? Or you decide based on the PD-L1 to decide, or you're just generally not sure. So if we could have some answers for this one. All right, go to the next. Now, if you are in that scenario, how do you approach that 4L lymph node? Are you going to do a mediastinoscopy and get it that way? Are you going to pull down and dig and try and get it by VATS? Are you opening that patient to be able to try and access the 4L? Or you just don't operate on patients with 4L disease that's proven clinically? Or you're not sure? Okay. Last question, I think, anyways. Now, what is your preferred surgical approach for mediastinal lymph node assessment? Or is everyone here going for formal mediastinal lymph node dissection in all accessible ipsilateral stations? Are you a lobe-specific person, but still doing a mediastinal dissection for those draining lymph nodes? Or are you more into the sampling of lymph nodes regardless of scenario? Do you adjust depending on the presumed stage of the patient? Are you one of those people who doesn't think it matters? or you're just not sure? All right. Now that we've gotten some sort of baseline sense of what everyone thinks in these sort of common situations, what's the data? So I'm going to try and blast through this in the next 6 minutes to give time to our cases. We have a few FDA approvals for the use of immunotherapy in the perioperative setting. The first one that came to light was Empower 010 for patients with PD-L1 greater than 1%. Without spending too much time on the data, you can see here that there was clear benefit with the addition of atezolizumab versus best supportive care in patients with stage 2 and 3A disease, but that there's a gradient of improvement in outcome as PD-L1 goes up. In terms of the OS, it's a little bit immature still. If you just take that greater than 1% group, as you know, adjuvant studies take quite a while to mature with these patients being already selected to be good performers based on the selection criteria. But although the approval here in the US is for greater than 1%, Canada and most places in the rest of the world, including Europe, have only approved it for 50% and greater, and that's because most of the benefit, in fact, I would say all of the benefit is driven by those greater than 50% patients. So while the trial was designed for greater than 1% and the FDA label offers it for those patients, it's probably only helping those with PD-L1 greater than 50%. So I think this is quite important in terms of counseling patients after surgery and guiding them with what their options are before they go on to see the medical oncologist. The other FDA approval, which is more recent, is from Keynote 091, the PEARL study. Very similar study. This one was placebo-controlled, comparing pembrolizumab for a year after surgery versus placebo. One important difference here is that chemo was optional, though strongly recommended, and the approval is based on this curve, which was the DFS in the overall population, and this was positive with a hazard ratio of 0.76. If you think back to the years of the adjuvant chemo studies, it's very similar hazard ratios as what led to the approval for chemo, but this is now coming to add over and above that. One of the important subgroups that did not benefit are the patients who did not get any chemo, and the recent approval in Canada is only for patients who get at least one cycle of platinum doublet in the adjuvant setting, though that's not the case here in the US. The other primary endpoint was in patients with PD-L1 greater than 50%, and this did not reach its endpoint. It was negative, and there have been a lot of discussions as to why that is. It's counterintuitive based on what we know of the metastatic setting. The best explanation I've heard is that the placebo-controlled patients actually overperform based on what the historical controls were, leading to this study being perhaps underpowered, maybe just immature, and so we will see over time whether this subgroup actually at some point derives benefit. We have two other studies that are in progress and for which we should have results soon. The ANVIL study, looking at adjuvant nivolumab, very similar design to Empower 010 and PEARLS, and the BR31 trial led by the CCTG group, which I believe will have results very soon using durvalumab in the adjuvant setting. Now, when we have patients who have less than 50% PD-L1 in the metastatic setting, we do not give them monotherapy. That is not what we do. What we do is we offer them concurrent chemoimmunotherapy. And so there's two important trials looking at whether adjuvant chemoimmunotherapy given concurrently can actually do better than sequential chemo followed by immunotherapy. This is the Spanish trial. It's a phase 3 trial that's completed its accrual. Dr. Provencio, who's led this study, tells me that they're expecting results in early January, of 2024. So keep your eyes out open for this one. And the American-led study, Alchemist ACCIO trial, which is comparing platinum doublet, an observation to platinum doublet plus pembrolizumab for a year versus platinum doublet, where cycles 1 and 3 are given concurrently with pembrolizumab, followed by pembrolizumab. So really trying to dissect that question, whether concurrent administration of immunotherapy brings benefit or not in the adjuvant setting. And I believe this is led by Dr. Sands. and we should have results sometime in the next couple of years. Now, I've said this before at other meetings, I really dislike adjuvant studies because they take forever to provide us results. You can see the OS results from Keynote 091. It takes a lot of patience. I'm not a patient person, and that's why I like neoadjuvant studies. And the other reason I like neoadjuvant studies is that adjuvant studies do nothing for all of these events that occur in the first 6 months or so after surgery. The only thing you can do to improve on this is maybe do better staging. But then we know that even when you do better staging, there's patients with micrometastatic disease. And so the only way to deal with that is to give preoperative systemic therapy. And we have an approval for that, which is the Checkmate 816 study for patients with tumors greater than 4 centimeters or ipsilateral positive lymph nodes. That was approved last year in the spring. Now we have the 3-year results for the trial. You can see a sustained benefit in terms of EFS starting right at the beginning with 57% EFS at 3 years. That's a 14% improvement upon the chemo-controlled arm, and basically a whole year of extra EFS in those patients who got those 3 doses of immunotherapy. This is time to death or distant metastasis. You can see a 20% benefit, 21% benefit on that at 3 years, which is very encouraging for such a small amount of drug. And the OS results, which are strongly encouraging and trending towards positivity. So on to the cases now. Dr. Ugalde.
Thank you, John. Thank you. Thank you for the invitation. Thank you to PeerView for the invite. So we're going to jump right away into our first case. Next. There we go.
There you go.
So this is a 44-year-old female patient, heavy smoker. She was asymptomatic when we saw her, and she had an incidental finding of a left upper lobe mass due to chest pain. No comorbidities, excellent lung function. And as you can see in both scans, this patient had a left upper lobe mass with important mediastinal lymph node metastasis that was described as bulky disease in the AP window. She went ahead and had a PET scan that, again, positive at the mass and very positive in the mediastinum, AP window, and also paratracheal station 4L. This is just to highlight the tumor and the mediastinal disease. To complete the clinical staging, the patient underwent an EBUS that was positive in station 4L, and she also underwent a transthoracic needle biopsy, which confirmed that she had an adenocarcinoma. We ordered molecular analysis, and she was negative on all of them: ALK, ROS, PD-L1, and EGFR. Would you consider this patient a candidate for neoadjuvant treatment? Can't say yes just because we are presenting the case. Just like a study, right?
Sounds like people are paying attention.
Halfway. All right. So the patient, yes, this case was discussed with the Dana-Farber medical oncologist. We offered neoadjuvant treatment. She underwent restaging with imaging. You can see in the CT scans that there was a response in size for the tumor and a significant response in the mediastinum with a decrease in size of that lymph nodes in the AP window. And the PET scan just highlights that all the lymph nodes now are negative. And the tumor had a partial response. So again, just to highlight pre and post imaging. So You know, I personally don't address lymph node station 4L through the chest. I know there are some surgeons that are able to do that. I am not. To assess that lymph node, we went ahead and performed a video mediastinoscopy. We started biopsying station 2L. We sent that lymph node for frozen. We took a couple of those lymph nodes in station 2. Those lymph nodes were much more mobile and free of adhesions. And then we started the dissection in station 4L. That was really, as you can see, stuck to the left main bronchus. You see a Surgicel there because station 7 had been removed already. So you know, we had to do kind of a dissection right there to really access those lymph nodes. I would have not gone to the chest without at least getting some kind of sampling of that area, at least. I must say that this patient was consented with 100% of coming out of this procedure hoarse. She knew that that was the price to undergo this procedure. So finally, we were able to find those lymph nodes in station 4L.
Paula, was the point here to actually remove the nodes
Yeah.
or sample them?
So
Well-
just for the online audience, we have a question whether the goal here is to remove the whole lymph node or just to sample them, Dr. Ugalde.
Well, my initial objective was to try to remove them. That's what I do when I perform VAMLS, but I would be happy just to be able to, you know, get good sampling. And we were able, as I was digging into that 4L, you know, space, we were able really to get good, you know, specimen.
Question for you, would you have aborted if they were still positive?
I think that that information would have been important for me. With the 2L negative and a 4L positive, by definition, we would have been able to achieve a complete resection, an R0. So I would have gone ahead, but I wouldn't have done the procedure without knowing that answer.
Okay.
So here now we're in the pleural space, and we're performing the same kind of lymph node dissection in the AP window. And as you can see, very bulky, thick, a lot of fibrosis. During this part of the dissection, we're trying to protect the phrenic nerve, which is right there, and that's why I stopped using the energy device. So it's going to be a little bit more bloody, but very stuck, very thick, and just doing our best to protect those nerves.
How long after completion of chemoimmunotherapy did
6
you?
weeks.
6 weeks.
Yeah. And as we were removing the lymph nodes, we were sending everything to path, and every single lymph node was coming negative.
Mm.
So stations 5 and 6 were dissected.
That's really nice.
Yeah, we were able to visualize both phrenic and vagus nerve, and again.
I also noticed that your dissection was only on the left side when you're doing the mediastinoscopy. Is that because of concerns around the recurrence? And
Yeah, I have a lot of concerns. So we've now have some experience using VAMLA for post the neoadjuvant patients, and when you open that device and you stretch everything in the mediastinum, I believe that you can harm the nerves. So it's kind of shocking. Post-operative, the patient did extremely well. She was not hoarse at all, which just tells me that probably I left some lymph nodes. And she went home this post-operative day 1, actually. This is final pathology. What's interesting here is that if you see tumor effect, viable tumor 30%, and then all the lymph nodes, all the 19 lymph nodes that were removed during this procedure was negative. So the final pathology was T2B by size and 0.
fantastic. All right, thank you so much, Dr. Ugalde. Dr. Najmeh, you're up next with a few more cases.
All right, so good afternoon, everyone, and thank you, Dr. Spicer, for the kind introduction and peer review for the invitation to participate in this session. As John was saying, I was invited to share some of my experience as an early career thoracic surgeon dealing with peri-adjuvant immunotherapy in the care of patients with operable non-small cell lung cancer. I think this is a very exciting time to be practicing thoracic surgery. As Dr. Spicer showed us, there's really unprecedented improvements in oncological outcomes, especially for patients with stage 2 and stage 3 disease. And the two cases that I will present just illustrate some of the clinical scenarios that we're now encountering as we're operating on more and more patients who undergo these preoperative therapies. So the first case that I'd like to present is that of a 70-year-old female ex-40 pack year smoker, just known for dyslipidemia and GERD. She was found to have a 3-centimeter left upper lobe spiculated mass with pleural retraction, as you can see on the scan, as well as some ipsilateral hilar adenopathy. You can see them right here on the scan, really kind of around the truncus equivalent branch of the pulmonary artery and really surrounding that left upper lobe bronchus. A PET scan was performed, and you can see some of the fused imaging on the right, which showed increased FDG uptake in the left upper lobe mass, as well as significant uptake in the left hilar lymph nodes. An MRI brain was done for completion of the staging and was negative, and an EBUS was performed at that point, and biopsy of the left hilar nodes revealed non-small cell lung cancer, favoring adenocarcinoma with a PDL1 of 30%, and an NGS showed a KRAS G12C mutation. Question here, so what would be your preferred treatment strategy for the 70-year-old female with an ECOG1, clinical T1N1 left upper lobe non-small cell lung cancer with a KRAS G12C mutation and a PDL1 of 30%. You can read the options here, but similar as we've seen before. All right. Sorry. Technical issue.
All over the map.
All right, let's keep going. No right answer, no wrong answers here. So if you were to offer upfront surgery for this patient, what operation would you do? That's left upper lobe and a node dissection, left thoracotomy, left upper lobectomy and a node dissection, a left upper lobe sleeve versus double sleeve. VATs are open, depending on how crazy you are, left pneumonectomy or something else.
And just a warning, we have a radiation oncologist amongst us who's paying very close attention to the discrepancies in these answers.
Laughing out loud.
Yes. Minimally invasive, sorry, I meant.
All right.
All right. All right, excellent. So we presented this case at our multidisciplinary tumor board, and the recommendation was to proceed with neoadjuvant chemo-IO. This was right after the Checkmate 816 trial was published, and we were all very excited about that, so we thought this would be a great patient for this treatment strategy. So the patient underwent 3 cycles of neoadjuvant chemo-nivo, and you can see the post-treatment imaging on the right-hand side. So as you can see on the CT scan, there's significant response in the primary tumor itself, as well as in the left hilar lymph nodes. So now we're after 3 cycles of chemo-IO with good radiographic response. What surgery would you offer the patient now, and is it any different from your pre-treatment surgery?
People feeling more brave.
we'll go to the results. All right, I like
Oh.
this. Very nice. Good. So that's also what we did. So we performed a VATS left upper lobectomy and mediastinal lymph node dissection. As you all know, many ways to do this. I do by 2 incisions, basically one axis incision and another 12 millimeter incision for the camera around the 8th intercostal space. And we extract the specimen from the axis incision up there. Surgery was uncomplicated. It was a little bit challenging working around the bronchus, which we've noticed kind of from our experience dealing with these patients, which also reflects the experience of the MD Anderson group that was recently published. A good response in hilar nodes after chemoimmunotherapy is truly one of the what makes these surgeries often very challenging, and this is what we've been seeing in practice as well. But despite that, everything went well, and the patient was discharged post-op day 2. The operative pathology showed no residual tumor in the primary. However, there was a persistent tumor in level 10L with no sign of regression whatsoever or no sign of response to the therapy. The other hilar nodes were negative, and all the mediastinal lymph nodes were negative. So that's consistent with a YPT0 and 1, consistent with a major pathological response. So just to remind everyone, pathological response has to be in both the primary tumor and the lymph nodes. So even if you have no tumor left in your primary, we can't really call this a complete response as there's residual disease in the nodes. So the reason why I wanted to highlight this case is there was a discrepant response in the primary tumor compared to the hilar nodes. In this case, a very nice, we started with a 3 centimeter mass in the left upper lobe, and there was nothing left on the pathology. However, there was no response whatsoever in those hilar lymph nodes. And we've been seeing this more and more in patients who are undergoing chemo-IO. And why that is and how we can improve on that is I think, something that's still unclear. And the implication of that phenomenon on future recurrence and long-term survival is, I think, something to look at and to watch for later on. So I'll move on to the next case. So this is quite different. This is a case of a 78-year-old male, ex-40 pack year smoker, who is known for hypertension, dyslipidemia, and a history of infective endocarditis in 2014, for which he underwent bio-AVR and MVR. He presented to the emergency room with mild hemoptysis, and a CT scan, as you can see here, shows a 4.7 centimeter left lower lobe mass with endobronchial extension and complete atelectasis of the left lower lobe. PET scan was performed and showed increased FDG uptake in the left lower mass, as you can see here. No obvious adenopathy in the hilum or the mediastinum. And brain imaging was also performed at that point and showed no evidence of brain metastasis. His pulmonary function tests were acceptable with FEV1 and DLCO between 60 and 70%. So the patient underwent bronchoscopy, an endobronchial ultrasound, and a biopsy of the left lower lobe mass showed non-small cell lung cancer favoring squamous cell carcinoma. The PD-L1 was around 20%, and lymph nodes 4L and 7 were biopsied and were found to be negative. So we discussed again this case at our multidisciplinary tumor board, and the recommendation was to start with neoadjuvant chemo-IO and then offer him surgery. He completed 1 cycle of chemo-IO. However, he presented to an outside hospital with severe scrotal cellulitis and bacteremia. And during that same admission that he had for antibiotic therapy, he developed kind of ongoing mild hemoptysis. Repeat CT scan was done at that time and showed relatively stable left lower lobe mass, bilateral ground glass opacities, as you can see here, which were thought to be most likely due to either aspiration or the ongoing hemoptysis that he had. So we discussed this case again at our meeting, and we decided to go ahead and take him to the OR for resection, as we did not feel like he would tolerate more neoadjuvant therapy. Intraoperative bronchoscopy showed an exophytic mass really protruding from the left lower lobe bronchus right at the secondary carina. The left upper lobe bronchus itself appeared to be patent and free of disease. So I really felt like this patient might need a sleeve resection at the time, so we did a left thoracotomy for him, left lower lobectomy, and a bronchial sleeve resection and mediastinal lymph node dissection. Operative pathology showed a 4.2 centimeter invasive squamous cell carcinoma. Margins were negative, and there was a level 12L lymph node in the specimen that was also positive. The other nodes, including mediastinal lymph nodes, were negative. So IPT2B and 1, note that there was no response whatsoever to the one cycle of chemoimmunotherapy in the specimen on final path. The patient ended up doing okay. He was discharged on post-op day 7. He was seen by the oncologist post-op to discuss adjuvant therapy, and he actually refused to have any because of his neoadjuvant experience. And despite that, he actually so far is doing okay. I recently saw him in my clinic a couple of weeks ago, 1 year post-op, and he's doing fine with no evidence of disease on his surveillance CT scan. And the main reason I wanted to present that case and maybe pick your minds at this is that bronchial obstruction can be seen in up to a third of non-small cell lung cancer cases, and obstructive pneumonia and atelectasis has been shown to be associated with decreased both overall and disease-free survival when we compare patients with same size, same stage tumors without evidence of bronchial obstruction. And the use of neoadjuvant systemic therapies in the context of endobronchial obstructive lesions has not been really studied. So we started looking at that with some of our fellows, who I see here, and we're hoping to publish this data soon, but our retrospective data show that there's definitely an increased risk of overall complication, as well as a significantly increased risk of pulmonary complications in patients with obstructive tumors of the main airways who undergo neoadjuvant therapy. And maybe as we're operating on more and more stage 2, stage 3 patients, this is something to really consider and to look at. And now that we're getting immunotherapy accepted and approved in kind of the adjuvant setting, maybe this is something we should take into consideration when treating these patients.
That was great. One of the questions that came into the chat here is whether there's any point in offering the patient interventional bronchoscopy to open up the airway prior to initiating. Is that something you've done or considered?
I think it's something we've done, for main airway obstruction, like right upper lobe tumors obstructing the whole right main stem bronchus, and you see the whole right lung down. We've done that in these cases. I think in a case like this, where you have a bulky mass in the left lower lobe, I don't really see a point of really doing that. I mean, if you're really trying to give this patient neoadjuvant treatment at all cost, I can see how this would be tempting, but in this case, I don't believe there would be much advantage to that.
Mm-hmm. It was a pretty striking complication from the preoperative treatment. Do you remember why this patient declined getting adjuvant therapy?
Well, he's a man.
He's Canadian.
It's very, very stressful for him.
He's Canadian.
Yeah.
Yes.
It was multifactorial.
But yeah, the patient, wasn't the fittest patient to start with, and I think, after he had the complication with the first cycle, he had to be hospitalized for a couple of weeks with the hemoptysis, and he just didn't tolerate the treatment well, so he was very reticent to accept adjuvant.
When you do neoadjuvant, do you stage CT, PET, brain, prior, and post, or do post you change a little bit? How do you do it?
We don't. Again, we're in Canada, so resources are scarce. We usually don't unless it's a patient who's on trial, or unless it's an EGFR patient. So patient without an EGFR mutation usually will get the CT, PET, and brain imaging, plus anything else that might be indicated with those results. And then they get the neoadjuvant treatment, and then we usually do just restaging CT scans. Unless there's signs of progression on the restaging CT scan, we might proceed with, PET and repeat mediastinal staging, but otherwise we don't. In the EGFR patients, we do, and we're more and more repeating brain imaging post-treatment, as we know that a lot of these patients do progress in the brain.
Dr. Ugalde, you had I
Yeah,
had
no,
a question.
I was just
what
going
do
to
you guys
say
do?
that when we, we bring the data from science to practice, right? Checkmate did everything before, everything after, and then surgery, right? So, and we see a lot of shifts when you bring that to real life. I think that in our institution, we aim to do PET, CT scan. I would say brain is probably the one that, sometimes is not done. But we have seen in the tumor board cases that, are going to surgery just with the CT scan. I personally try to do everything.
Yeah.
I guess the real question is, what is the incidence of, how many times do you do a PET and you see progression of the disease that we did not see on CT scan? It's definitely an interesting topic that I think is worth looking at.
We'll take questions just at the end. I have a few more slides to go over, but this issue of restaging is important, and we'll be presenting some stuff at ASCO that might help around that. It's about 3 or 4% patients who have distant progression that'll justify the PET. So you have to do a lot of PETs to find a few patients that, and those patients are oligometastatic. So really, does it really change your decision making? I'm not sure. Okay, so this was perfect to kind of come into some of the more recent data, and I'll do this quickly again so that we can get to your questions, because I think it's always the discussion that's most enlightening. Part of the reason I was asking you guys what you do with your mediastinal node dissection, we thought that some of these cases were particularly pertinent, is around the most recently presented recurrence pattern data that Dr. Ford presented at the European Lung Cancer meeting a couple months ago. You can see that preoperative chemo nivolumab dramatically reduced the distant recurrence rate from 22% to 10%. And in fact, most of this was mediated by diminished brain recurrences, where you have 13% in the chemo cohort versus 4%. So tumor kill in the primary and lymph node is effectively being translated with diminished distant micrometastasis, which is, I think, why we're curing more patients by this approach. But we're not really accomplishing a whole lot at the local regional level, which is a bit surprising. 22% local regional recurrence in the chemo-treated versus 19%. We have a lot of intrathoracic lymph node recurrences and a few lung and pleural. So the only thing we can do, in my humble opinion, is do complete node dissections, and perhaps that's an important part of it. It was not mandated in Checkmate 816, it was recommended. I'm not going to go through all of the data by region, but North America did not perform particularly well in terms of getting R0 resections. And part of that goes to what Dr. Ugalde was talking about, which is getting that highest lymph node and assuring that it's negative, because by ISLC criteria, that's an R+ resection if your highest lymph node. Whether that is truly R0 or not, it certainly corroborates worse prognosis. So I think we have to do due diligence and make a good effort to do complete node dissections. We have the NeoTorch study that just came out. This is a Chinese study with giving 3 doses of toripalimab, a checkpoint inhibitor with chemotherapy versus placebo plus chemotherapy, 3 cycles plus a 4th that can be given in the adjuvant setting, and then maintenance thereafter. This study is a phase 3 study recruiting about 400 or so patients. There was a benefit in terms of PCR that was comparable to what we've seen with other similarly designed studies, as well as a very significant EFS benefit. So confirming that this design of peri-adjuvant is at least comparable to what Checkmate 816 demonstrated. But we have some, and I apologize, I think we might have omitted to put the Asian data, but it's essentially identical in terms of the EFS benefit that was seen. The surgical outcomes, though, bring us some questions. R0 resection rates are not where we'd like them to be. We have R0 resection rates at Checkmate 816 that are around 83%. AGN, however, and NeoTorch were much better in the mid-90s. So was this because the selection of patients was a little bit more stringent? Certainly AGN did not allow for patients who might need a pneumonectomy at entry, so that will certainly improve your complete resection rate. But there are issues with progress to surgery. In AGN, it was somewhere around 20% of patients who didn't go on to surgery, which is similar to CheckMate 816, and also similar findings in NeoTorch. Now, there are a lot of differences. Cross-trial comparisons are never the greatest, but if you look at CheckMate 816, NADIM2, AGN, and NeoTorch, which are the randomized studies we have, NADIM2, the exception being a phase 2, all the 3 others being phase 3, look at the EFS at 2 years. There are differences in stage, there's slightly differences, some important differences in the therapy. CheckMate 816 was only 3 doses of immunotherapy, but we've already hit a plateau. We've only been doing this for a few years, and kind of like with chemorads and surgery, or chemo and surgery, where we hit a plateau about 15 years ago in terms of the outcomes with those modalities, we seem to be hitting a plateau here, and it's really unclear what the added benefit of that extra year of postoperative treatment is, although it will become an option for us and might already be so here in the US, with Keynote 671 having announced its positivity by press release, the results of which will be reported at ASCO, but I understand there's already a pre-approval through the FDA for that regimen. There are a couple other studies, Empower 030, BMS 77T, and another Asian study comparing tislelizumab with a platinum doublet that will be showing results in the coming future. So we'll go through these polling questions one more time. Please bear with us as we check in with you again. So for stage 3 patients, what is your preferred approach? Upfront surgery, regardless of PD-L1, upfront surgery, and then tailoring the immunotherapy based on the PD-L1 level, neoadjuvant chemoradiation followed by surgery, neoadjuvant chemoimmunotherapy followed by surgery. Give you a few moments to answer that, and we'll look at the results. Yeah.
Oh.
All right, so some evolution in so more people trending towards neoadjuvant therapy. That's interesting. Can go on to the next one. This one's for stage 2. So this is same options. I'm going to just talk through it as you answer. I think this is one where there's more controversy. And stage 2 is not, we know there's stage 2A, no negative, stage 2B. They're probably different beasts, at least in my mind, but they were analyzed together. I remember CheckMate 816 was stage 1B from the AJCC7, which is 2A from AJCC8, sorry. So it's really stage 2A, 2B. But they were analyzed together, and really no benefit over chemo with that small cohort, as far as we can tell. But there are benefits to chemo on its own, and that being the control arm versus upfront surgery. It's hard to know where it all fits. So what do people think here? How are you approaching these patients? Do we have the results? So here it seems that we have more patients going to, okay, there's a slight shift. What's number 3? Upfront surgery followed by chemo. Okay, so I guess we've influenced folks that your use of immunotherapy in the adjuvant setting should be tailored to the PD-L1 level. I'm happy to see that. And then quite a few more people offering neoadjuvant chemoimmunotherapy to stage 2, which I think is very interesting.
What are you doing?
Oh yeah, we give it to everyone. The reason being that, and I'm giving a couple other talks, one on Monday, where I'm not really debating, but kind of debating Jay Lee on whether it should be given up front or afterwards. There's never been a study where preoperative therapy had worse outcomes than upfront surgery. It's just, there is zero data on that. And usually the fear that I hear from surgeons about giving neoadjuvant therapy is that, oh, you're going to miss an opportunity for curative surgery. Well, just a few weeks ago, I did a segmentectomy on a 45-year-old woman who had negative brain imaging, and She had an EGFR mutation. We were going to enroll her in a DARA-2. She has an MRI of the brain for pre-enrollment. There's 5 brain mets. So I mean, upfront surgery usually will not do anything to prevent those metastatic events. So it's more about we need better measures of metastatic disease. And I think stage 2 is as good as we have currently to say they are at a higher likelihood of micrometastatic disease. Let's give them the benefit of the doubt and treat them. And we've not had a stage 2 patient that's not made it to the operating room. Okay, next question. Preferred strategy for this. So this challenging situation that Dr. Ugalde described, how are people approaching this now with the description of the case? I'm very curious to see what people have to say about this. Let's see. Okay, results. Oh, you were very influential, Paula.
It must be my Latin accent.
Yeah. I mean, I think that was a bold case because it was a PD-L1 0. It was not subtle adenopathy. You had a lot of periaortic disease. Now, it's one case. You had a good response. I've seen cases go the opposite direction, but I think you've done that patient a favor, and it really turned out well.
I think that there are some cases that we need to focus on the exclusion criteria, not so much on the inclusion criteria. So she wasn't N3,
Right.
rule that out. She wasn't EGFR.
Right.
It was a lobectomy.
Yeah.
You know, so there were several points that said,
Yeah.
okay, there's no reason why to exclude her.
Yeah.
So why not include her?
I think that's great, and you did a remarkable job of really rigorous staging, and the whole point about, I didn't even think of that, about plucking 2L out and convincing yourself that you were going to get ours. I mean, I think that's really well done, and sounds like you were convincing to the group. So now how do people approach, all right, yeah, here we go. Preferred surgical approach for the 4L lymph node. I thought that was really elegant. I mean, before you answer, I'm going to preface it by that was a really elegant mediastinoscopy. So what do people do here? Are you going to do a mediastinoscopy? You're going to still try and get by VATS or open? Are you still not operating for 4L patients?
I think the other question here also that's, I mean, we can go ahead and present the results. I think that the other interesting question you kind of alluded to is, do we need to remove those lymph nodes?
Mm-hmm.
I mean, there's a lot of work coming out from Memorial Sloan Kettering showing that you should remove the tumor bed.
Mm-hmm.
But is lymph node considered a tumor bed, or is just the lung the tumor bed?
Right. That's an excellent point.
Like if you biopsy those lymph nodes 3 bus, right?
Yeah.
And it comes negative. Should we remove them?
It's a good point. And why expose the patient to that
Yeah.
perhaps recurrent nerve injury risk? I agree. So here we have most people going to do this by mediastinoscopy. Again, it sounds like you were influential. And a lot of people who are unsure. So that's good. Interesting. Very good. And a few people are now convinced to operate. Which we like, right, Drew? All right, next slide. So what is your preferred surgical approach for mediastinal lymph node assessment? This is controversial. Everyone does something a little bit different, even though I feel we should all just dissect, but what do people do? All right, let's see the results. All right, so I think, yeah, I'm happy to see that most people are doing node dissections and that maybe a few more will do it. I think it's particularly pertinent now, I think it's quite valuable prognostically to know that the patient may have persistent nodal disease. And now that we have perioperative therapy, maybe those are the patients who need to continue treatment. Any thoughts on that?
Do you think that the R classification should be exactly the same for patients undergoing upfront surgery versus patients undergoing neoadjuvant? This is something that we've been discussing a lot in the ISLC staging committee.
Well, I think all the trials should use the same R classification, which they are not. And so I think people need to be aware of that. It's the same thing with MPR. PCR is pretty universal. There's got to be no tumor anywhere, and maybe you can ask your pathologist how carefully they check, because that's probably where the most discrepancy might be. But for example, in 671, this notion of the highest lymph node, that's not part of the R. The R uncertain is not included in 671. So it's really marginal disease if you have a tumor coming to the margin. 816 was much more aligned with the ISLC. So if you had lymphatic LVI all the way to the bronchial margin, even if your tumor was 3 or 4 centimeters away, that was an R1 disease. So these differences really make big differences in terms of the statistics you see. But I think we have to kind of all get on the same page about what we're measuring moving forward, certainly for the real world evidence that we'll be collecting. All right, so I think that's all the questions. We'd love to hear from you guys in terms of, Dr. Spicer, please have audience questions. Go to the aisle to use the microphone. Go ahead, please.
Great job, all three of you, on presentation. John Howington, Bremerton, Washington. So let's look at, in the U.S., you mentioned that much more liberal use of immunotherapy or targeted therapy and the marketing of that, and specifically talk about Checkmate and the others in stage 2A, but they're saying stage 1B because it was the 7th edition, and talk about the confidence interval in the truly node-negative patients that had a 4.2 centimeter tumor, and what's our evidence that we need to be doing that in a 4.2 centimeter tumor? Thank you.
So maybe, Paula, what are you guys doing? Are you treating those patients? I mean, you're treating them, but are you giving them preoperative treatment?
I think at this point is very much driven by the surgeon that sees the patient and the oncologist. I don't think that we have, Scott Swenson is putting a lot of effort to try to, we're 20 plus thoracic surgeons at the Brigham, which is a huge machine.
Good luck.
I think it would be a dream to kind of at least have 80% of us doing kind of the same thing. So I think at this moment, realistically, everyone is doing what they think is better. I think it has to do also with the type of resection, like an easy right upper lobectomy.
Yeah.
I mean, it's appealing to take the patient to the OR. And also, you do have adjuvant immunotherapy.
Mm-hmm.
So.
Sarah?
Results from the studies?
So I'll get to that in a second, but Sarah, what's your...
Yeah, I completely agree with Paula. It really depends on who sees the patient, not just which surgeon, but whether they get to the radiation oncologist or the medical oncologist first. And a lot of the kind of downstream treatment often depends on that. I think for me, when I see the patient for the first time, a patient with, like a 4.4 to 4.5 centimeter mass, looks like node negative, the way I think about it is if let's say I do upfront surgery and it comes out as a 4.2 centimeter tumor, what we can offer this patient in Canada right now is adjuvant chemo. And oftentimes when the oncologist discuss this option with the patient, they tell them, the kind of
5%.
you have 5%, increase in survival, and that's I think a very hard sell for the patient. And most patients, again, Canada is a little bit different, will actually not end up getting any adjuvant therapy. So that's one of the reasons why I tend to be more aggressive and encourage neoadjuvant therapy, because then I know the patient will get it.
Yeah. I think the other answer is a bit statistical, and I personally wasn't really trained in that formally, and I'm learning more and more about it. But when these trials are evaluated by regulatory agencies, the size of the trial in terms of whether the subgroups can be decisional or not is quite important. So if you have Checkmate 816, 360 patients, and only a very small proportion, it's basically 30 patients in each group that had a stage 2A tumor. You can't make decisions based on that to say whether you should or shouldn't give treatment, and we don't have the control group of upfront surgery. The outcomes for those patients with upfront surgery are not good. There are a lot of recurrences in these people. The surgeons who tell me that they're cured by an operation, yeah, some are, about half are, we need a better biomarker in those patients. That's probably where we need ctDNA and things like that to have a better evaluation of whether they have micrometastatic disease. In the absence of that, I try and give them a regimen that gives them the most of all the available treatment options, which tends to be chemo, nivo, and surgery. Question? Yeah.
Yeah. Thank you for the excellent presentations and nice cases. Gregor Kocher from Bern, Switzerland. I have two comments or questions for you. First, the case that Paul Ugalde has presented. What I think is also important, I mean, you can biopsy, you can make an EBUS of the station 4L. If it's negative, you don't have to resect, you don't have to put the patient at risk. If it's positive, you should remove it, and I think you should remove it to see if there's extracapsular extension of the lymph node, because then you don't have an R0 resection, a patient might need additional irradiation. So that's my take on this. The second thing is, you talked about scarce resources, that you don't do all the restaging afterwards, but what's the rationale of giving chemo and checkpoint inhibitor to patients with smaller than 1% PD-L1 expression? I mean, we know more than 50%, of course, patients should receive chemo and checkpoint inhibitor. Between those 1 and 50%, I think there's a lot of discussion, but in those smaller than 1%, I don't see the sense now. It costs a lot of money.
She had complete nodal response in her case.
Yeah.
In her case, yeah, but
Less
there's
than 1%.
some cases, and
Yeah.
I mean, is this enough to treat all the patients?
It's a good point.
Irrespective of the status.
Did you guys not check TMB in that patient?
Yeah, it was
So
very high.
Yeah.
Did.
So I think one of the issues is preoperative biopsies, depending on where you're sampling, like we know that lymph node sampling tends to yield higher PD-L1s than if you're sampling the tumor. If you're in the wrong part of the tumor microenvironment, you might be negative, it might be positive if you're in. So I think the assessment is inaccurate. PD-L1's not a good biomarker. If you just look at the path complete response rate in the PD-L1 negatives, it was about 17% in the chemo-nivo patients versus about 4% in the. So I give the patient the benefit of the doubt in that setting, and then I consider what are the alternatives for that patient. The alternative for that patient is surgery followed by chemo, because there's nothing else afterwards. Right? Can't get. Or yes, absolutely. If you want to be really like strict about cost utilization and maybe but I think giving them the benefit of the doubt for the cost of those 3 doses of drugs is a kind of reasonable compromise. But that's sort of personal opinion. It's also, it's not supported by data yet, but it's also what we would do in the metastatic setting. So that's kind of the rationale. Any additional?
I mean, let's not forget that the AGN will be approved, and it was irrespective of independent of the PD-L1 level. So, I mean, we're kind of moving away from the PD-L1s,
Yeah.
but they should be EGFR negative. So I would say EGFR we still have to test.
We have time for.
I also advocate for chemo and checkpoint in patients that have lower than 50%, but our oncologists
Won't do it.
give it.
Yeah.
So just that you know, my take on this is similar, but we don't have proof.
Yeah, oncologists are very concerned about subgroups. A couple more questions, and then we'll close up.
So switching gears a little bit, and to your point, Jonathan, regarding giving patients the benefit of the doubt. So rather than sort of quibbling about the 4.1 or 4.2, I want to focus a little bit about the case that maybe Paula showed. The 45-year-old who we all say we need to go to bat for here. You've got a 9-centimeter tumor, 3-centimeter nodes encasing every blood vessel in the chest known to man. So you want to go, so therein is the decision making. Do we give this a chance with neoadjuvant, or do we go with Pacific? And do we lose out if we've given that patient the chance and there is no response? What are we left with? And this sort of brings me back to my days not so long ago, maybe 8 years ago, where our radiation oncologists, we have few in the room, thought it was heresy to just give chemotherapy without radiation in the neoadjuvant setting because the efficacy was better in a concurrent fashion. So again, where do we draw the line? And I think we need better markers for response, clearly. But shy of that, how crazy do we going to go in the preoperative setting?
I'm not going to take that one.
I mean, I kind of responded to that question. My thinking process is to go through the exclusion criteria. So she doesn't fit any exclusion. She didn't have N3 disease. She was not EGFR positive. This would be resected by lobectomy. We have all resect 4L lymph nodes. So the station 2 was negative from the beginning, and then during.
You've got a 3.5 centimeter node all along the.
So borderline resectable.
No,
Yeah.
no plane of the pulmonary artery.
Okay.
8 years ago, that was a bulky N2, and
Sure.
most people wouldn't be trying to resect.
And you've got AP window and L4. And that whole AP window is now just a 3 centimeter massive tumor.
Sarah, what are you doing for that patient?
I think, you have to see what the options are. And I mean, the way we do this is we have a multidisciplinary lung clinic, and we literally,
We always fall behind the multidisciplinary lung clinic.
Okay, he's pushing us on this one.
we said these are,
Easy cop-out answer.
Okay.
Yeah.
Yeah, well, I think it's important to say this is a CME approved. So none of these studies were for that patient, right? That's not what the evidence we have was generated to answer. We are in a position now where we want to do everything possible. We have this inherent belief that offering a patient a path to surgical resection will be the better option, but we don't have evidence to support that either. I know you're watching me very closely, Drew. So I think we need trials in that space of the borderline patient. There are some coming forward. I do think the MDT and the patient and the shared decision model is really critical there. If the patient wants surgery, is fit for it, and wants to take that risk, we do that for oligometastatic disease all the time. And in fact, our radiation oncologists often will ask for that patient where it's going to be a large field and maybe hard to fit it all in. They'll ask, let's give them a course of systemic, see, and restage. But it's a different mode of thinking there. I think you're going to restage, and it's a decision tree with the team to say, okay, well, based on the response, are we now in a good position to operate, or is it better to consolidate with radiation? And it's sort of an open decision with the patient. I think trying to make a determination at first presentation for that patient is not good, but the idea of starting with systemic, I think, is a great way to go. For both, whether you're going to go to RT or surgery. And sometimes we'll restage after the second cycle in that setting. And you're like, oh, look, this is maybe there's an open window to offer an operation, patient's fit, and we do it. Last question, and then
She's going to change the.
Yeah.
Now, Jonathan, and you mentioned on stage 2 your preference is now neoadjuvant therapy. What do you do with the EGFR positive patients, and what would your algorithm be there?
Yeah, well, I think that we don't have great data there, right? So we tend to do upfront surgery for the most part in those. There have been a few settings where we've given off-label preoperative TKI, but the upside is really marginal. I think when we've given in preoperative TKI outside of a trial setting is if we thought that we could downgrade the operation, make an open surgery, minimally invasive, or take a stage 3 down to something that's more contained. Do you guys have a similar approach? Or?
Did he ask N2 disease in EGFR positive?
No, stage 2 EGFR positive.
Stage 2 EGFR positive?
Yeah.
Oh, definitely surgery. I mean, the ADAURA data is that what he's talking about?
Yeah.
Yeah, I mean, the ADAURA data, I think that one is in fact, I'm actually very in favor of N2 disease. I mean, if I have a right upper lobectomy, right upper lobe cancer with station 4 positive, and the patient is EGFR positive, and he qualifies for the ADAURA trial, I mean, this patient should go under We've discussed this before,
Yeah,
right?
yeah,
Upfront surgery and then osimertinib post-op.
So no chemo by itself?
I mean, we have the new
upfront.
ADAURA open now. Dana-Farber has it open, and I think we're trying to include patients in that trial. But I think they're struggling. That's what I hear, to include those patients. What do you think?
I mean, I love the concept of Neo-ADAURA, and I'm very excited to hopefully recruit patients to that. We have taken a few patients now for upfront surgery, and the issue with that is we have had some surprises, bad surprises, sometimes intra-op finding either pleural disease or really more extensive adenopathy than what you thought. Oftentimes, I think our staging is not very reliable for these patients. And then, what do you do from there? And usually just kind of abort the procedure. So I think, if you catch them, and if you think you catch them early, then for sure up front, if you can get them onto Neo-ADAURA, hopefully that will help us get better outcomes in these patients. But I think it's a very difficult patient population, and I hope that trial will give us some promising results.
Yeah,
Thanks.
I agree. We had a great presentation in the earlier session on ALK inhibitors for these patients. We've done that. We've done it a few times for ROS patients. So it's a moving field. And anyways, thank you everyone for your attendance and participation. And I think we're on to the plenary now.
Thank you.